Hey,
I've been thinking about you. You want to grab a drink later?
I can't.
You know, when I say grab a drink, I don't really mean grab a drink.
I do.
I think that hookups and like dating probably a little more.
Lauren. Your glove.
Uh-oh. So her glove broke. I don't know if that's her blood or the patient's blood. Hey guys, my name is Jamie and I'm a fourth-year emergency medicine resident in New York City. I've been getting a lot of requests to react to the show called New Amsterdam, which is a medical drama set in New York City. So let's get right into episode 1. This is how I prefer to drink my coffee.
EMS just dropped off.
Is that a dead person being wheeled into the ED? So that's typically now how it's done. So usually EMS brings patients to the emergency room if there's something to be done. So if they're in cardiac arrest, they come to the emergency room because there is ongoing CPR going on and we can maybe do something to bring them back. If there's nothing to be done and they're not going to attempt resuscitation, they typically just go to the morgue. They don't pass through the ED to go to the morgue. And it seems like the doctor just came in, chugged the coffee, which is how I usually prefer to drink my coffee, and then start seeing patients right away almost. Typically when you're an attending, which I think Dr. Bloom is, you get sign out from the neg team if this is a morning shift. So you wouldn't just come and start seeing people unless you're starting in the middle of the day. So you would come in, get sign out from the neg team so that the neg team can leave, and then you can start seeing new patients.
Grab a sheet, will you?
EMS just dropped off.
Wait,
What?
did you hear that?
Hear what? Dr. Bloom, she's dead. No pulse, no BP, cyanotic rigor mortis.
I need a defib ventilator, ALS, and resuscitation team now.
That's impossible. She's dead.
Well, at least you didn't kill her twice.
I don't know what she heard, but I guess she heard something that maybe made her think that she wasn't like fully dead. So they're gonna now do the ACLS. The most important part of CPR or ACLS, if you're trying to bring somebody back, someone who's in cardiac arrest, is ongoing compression. So you don't want to go too long without your heart beating if that's what's actually happening here. So you wouldn't just like pause, you would like immediately start compressions.
Hey, Reynolds.
One second. Hey,
I've been thinking about you. You want to grab a drink later?
I can't.
You know, when I say grab a drink, I don't really mean grab a drink.
I do.
I think that hookups and like dating is probably a little more common in med school and maybe like early residency just because more people tend to be single. I haven't seen a ton of like dating happening like inside the residency or amongst the attendings. But with that said, a lot of the attendings are married because they met in residency or because they met in med school. Yeah, you can totally date if you're single and available and working in the same place. I don't know if you have to tell HR. Maybe you do.
No idea how you managed to keep this hospital afloat with so little help. So I'm going to hire you 50 new attendings because untrained residents will no longer be running this hospital, regardless of how much money their university makes off their indentured servitude or how much time it affords some of you.
So I'm not really sure why attendings are upset that more attendings are being hired. Maybe this is like a resident perspective, but I feel like in a residency run hospital, residents do a big bulk of the work that's required in patient care. So rounding on patients, writing notes, writing almost all the order, communicating with patients and their families and nurses. So if this is a teaching hospital, it's nice to have more attending because that means they can practice independently without having like further oversight by other attendings. So I'm not really sure why people are upset here.
How can I help? Yeah, person not calling their lawyer.
Lauren Bloom, emergency department. I want to get rid of our waiting room.
Okay, where do you want to put it?
I want to get rid of it. I want to move patients direct to bed, no waiting room.
So my hospital actually does this. It's called direct bedding. Basically means that instead of patients waiting in the waiting room and then being triaged and coming into the emergency department, they are triaged and then brought into the department right away, into a room or into a hallway with the stretcher The benefit is that you get to see the sick people early on so they don't decompensate in the waiting room. And then also from a stats perspective, your waiting room minutes are a lot lower because you're not really waiting in the waiting room. On the other side of that coin is patients feel that when they come into the department that they should be seen right away by a doctor or a nurse, which isn't always the case. Sick people get prioritized, but if you're not immediately decompensating or dying, you do wait inside the department for a doctor and a nurse to come and see you. The waiting room is just moved from the waiting room to inside the department. So sometimes patients feel like they're still waiting and they're not being paid attention to. The waiting part is probably still the same for most people.
Respiration shallow or weak. Give me a CBC, BMP, Chem 7 in the saline lock. Anybody know who this is?
Found a boarding pass in his pocket.
Stop. Everyone, back away from the patient. Masks on, now. BSI protocol in effect.
This is Max.
We have a patient in the ED from Liberia presenting with all the signs of malaria, Lassa fever, TB, or
Ebola.
That's bad. So this is always kind of a thing that we should be keeping an eye out for in triage. They always ask, have you recently traveled? Do you have fever? What are some of the symptoms that you're coming in with? Just to make sure that you can minimize contact with all the other providers and patients that are already in the emergency room. With the pandemic, this has been much less of an issue because almost everyone is already wearing an N95. There's, goggles or eye shields. So people are generally just a little more protected than how we used to be in the emergency department, which is without a mask and without goggles or eye shields. From that perspective, the pandemic has helped providers be a little better prepared in terms of dealing with these illnesses.
The patient is in an isolation chamber with negative pressure airflow. That chamber is equipped with every available medicine should the patient need to self-medicate. Everyone interacting with the patient is required to wear personal protective equipment at all times, no shortcuts ever.
So negative pressure rooms, super important. It was important in COVID. Where I work at Cornell had several of these negative pressure rooms where the air flows in but doesn't go out. So whatever viral or pathologic particles stay in the room with room opening and closing. There are certain rooms that are positive pressure, meaning things are constantly pushed out so that things don't come into the room. Those are different kinds of rooms for different purposes. Ooh. That looks like hemoptysis. That's not good.
Hemoptysis, he's crashing! Hey, can someone help me in my suit? Alon, you need to grab the oxygen mask. Alon, it is right above you. Helmet now!
So protecting airway is of the utmost importance when there's hemoptysis situations. These are one of those kind of scary nightmare situations because the hemoptysis means you're coughing blood, so there is blood in the airway. It makes intubation and other measures of protecting your airway much more difficult. He's statting 97%, it looks like, which is reassuring. And his respiratory rate, it says, is 15, which it didn't look like that.
forget it. I'm going in.
Dr. Bloom, wait!
No! At least we're at N95. So obviously, this is not a recommended behavior. You want to make sure that you're protected. Of course, patient care is important, but if you're exposed, then you endanger other patients, other people in your lives. So standard procedure would be for you to protect yourself first and then go in.
Bloom! Get out of there now!
Too late! I'm already in! There's too much blood! I can't see anything!
So I think when she says there's too much blood, I can't see anything, she probably would mean if you were to try to intubate from above the way we normally do through the mouth, she wouldn't be able to see anything because there's too much blood. It looks like she's now attempting like a needle cricothyrotomy. That's orange, so I believe that's a 14 gauge needle. Usually with pediatric population, we do needle cricothyrotomy, and then with adults, or older children, you can do an actual crike with a scalpel. I don't know how old he is, but typically you would do scalpel, and then you want to make sure you have everything else ready also. So you want to have the bougie, and then you want to have your ET tube. With the needle, you need an adapter from an ET tube, which is an endotracheal tube. And then you want to have your BVM, which is the bag valve mask, ready so you can give air to your patient. She's putting in the needle. See how that's set up, it looks like.
Heart rate is dropping. He needs adrenaline.
I can't stop bagging.
Adrenaline is another name for epinephrine, which is a pressor that you can use for someone with low blood pressure or someone who is dead. If their heart stops, or if they're crashing.
Adrenaline first, oxygen after. Okay, go.
So that, what she took out is called push dose epi or a co-dose epi. Normally we use that only when the patient's heart has stopped. Typically we don't use it for a patient who has a pulse.
Okay, now push 10 ml.
But those are pretty scary vital signs. He's if he's like a normal adult, then he's hypotensive and he's hypoxic. So he's 82/40. That's not good. He's setting 64%. That's also not good.
Now push 10 ml. Open wide.
That's too much.
Not for this kind of virus.
It will send us home.
I guess they're assuming this is potentially Ebola, which I'm not terribly familiar with. So maybe Epi does work well for something like Ebola, but we'll see.
Too high.
Push 10 hard and fast right now.
That would have been my first response too, that I wouldn't want to give a full cardiac dose Epi to someone who still has a pulse and is still alive. But that is what she's doing. And he's better. His heart rate's now 80. His blood pressure, I don't know where his blood pressure is. There isn't one, but presumably it's going to be better. You would also become tachycardic from getting Epi. His SATs are better, which is probably not from Epi. It's probably from him being bagged with oxygen. I think in these emergency situations, it's really easy to get kind of tunnel vision because you're focusing on like, what do I need to do right now because the patient is about to die? And it's really helpful to have another person kind of be the lead in giving directions. So that's why in all resuscitation scenarios, there's always somebody at the foot of the bed running the resuscitation, telling people what to do. And then there's usually another person at the head of the bed, either doing the intubation or doing other procedures. You don't want to be doing procedures and thinking about the whole picture at the same time because that's very difficult. So in this scenario, there's one person giving medical directions and then the other person doing the procedures and actually doing kind of the dirty work of all the procedures and resuscitation.
Lauren?
I know what you're gonna say. That was stupid. I violated protocol.
Lauren. Your glove.
Uh-oh. So her glove broke. I don't know if that's her blood or the patient's blood, but if this is Ebola, that is almost certainly 100% transmission from getting that blood-to-blood contact.
Alan, that shot they gave you in Liberia, they might have thought it was Ebola, but it wasn't. It was the Lassa virus, which is just as deadly. Except, as Dr. Bloom can tell you, the Lassa virus can be treated with antiviral medication, which we gave you.
So at this point, he's awake, looks much better. Usually after patients get criked, there's like a revision of that and people get trached. And that's more of a long-term solution to having a definitive airway. I don't know if this is like in the ICU or ED, but there's like all these people from the hospital there clapping for this ED physician. I feel like that would not happen in real life. I guess one thing I want to point out is Dr. Bloom, who's an emergency medicine physician, is like all over the hospital, which typically doesn't happen. You normally just stay in the ER because there's patients coming in constantly. When someone sick comes in, you stabilize them and you hopefully send them up to the ICU, and then you see all the other patients that come into the ED. So you want to just like spend all your time with one patient in what looks like an ICU setting, but usually patients go upstairs. You don't go with them. You stay in the ED. So that's it. That's it for episode 1 of New Amsterdam. I think there's definitely some things that are unrealistic to how things work in the real hospital and real emergency department. But I guess you need the ED person to be mingling with all the other hospital people for it to be like a drama. So I think that's probably what happened. But yeah. I'm definitely interested, and I'm gonna probably keep watching and see how the story turns out and how accurate the medical information is from the show. Hope you guys enjoyed this video, and I'll see you guys in the next video. Bye!
Of course.